So how's everybody doing for a Monday of week 5? Really hard to believe we're week 5 already.
Good. How are you?
Yeah, I'm doing okay. Okay. Um, Anybody have any burning questions before we get started? So over the weekend, we posted exam 1 grades, and for the most part, everybody did well. Okay, there were a couple of students who did not get the scores they expected. But for the most part, everybody did very well. So very proud of you. Hopefully you took advantage of the week 3 concept review. Hopefully you took it. I had a lot of students, or we had a lot of students attend exam 1 reviews, whether it was mine, Dr. Copteros, or Professor Ford. So hopefully those helped. And then you had all of the recordings. If you didn't take advantage of the live reviews, hopefully you took advantage of watching the recordings. Did you do that? Yeah, were they helpful?
I did. Yeah, they were a lot
Okay,
helpful. Very
fantastic.
much.
Great, great, great. Well, congratulations on all the fantastic outcomes. Um, so the announcement was sent out. Let me just let these people in 1 second. um, Over the weekend when we posted the grades. So if you score below a 78, it really is highly encouraged that you reach out to your instructor and schedule a tutoring session to see what concepts that you struggle with. I mean, certainly we can't pull up the exam and go over the exam questions, but we can talk about the concepts that you might have struggled with. So if you score below a 78, even below an 80, I highly encourage you to get with your instructor and schedule a time. And that was asked in the announcement. If you
I
score
don't
below
know.
a 78, reach out, give us some days and times this week that will work, and we'll go ahead and schedule a
Hold
tutoring
on, I'm turning
session.
her down.
Hello? Oh, um, and then again, if you scored, and I mentioned this in the announcement, if you scored above a 78, 80s, 90s, and you'd like to review the concepts, the questions from the concepts that you struggled with, please reach out and schedule a time to meet as well. Okay? We're happy to review any of the exam concepts with you. Okay? Does anybody have any questions about the exam? Okay. So today we'll start out by doing quiz number 3, which covers weeks 4 and 5 content. Um, and then we'll go through the quiz, and then we'll talk about all the concepts. We have a lot to cover today from weeks 4 and 5, all the concepts. So we'll cover that after we review the quiz. How does that sound? If you try to access the quiz before 3 o'clock, you're going to have to refresh. Okay, it is open. And the passcode, I'll put that in the chat. Um, the passcode is my last name. Right, so it's in the chat now. So go ahead and let's see, 15 minutes, it's 3:05. So we'll come back at 3:25. Okay. 3:25. If you finish early, you can go off camera. I wouldn't log off from Zoom, but you can go off camera. But everybody needs to be back by 3:25, and we'll get going with class. Okay. So refresh the quiz if you tried to open it in the before 3 o'clock. Okay. Do you guys see it? Yes. Okay. I have a lot of head shakes. Okay. I'm going to go on mute. Please stay on camera during the quiz, and we'll see you in a few minutes. Okay. And if everybody could make sure they're on mute. And then if you have any questions, just put them in the chat. I'll answer them in the chat. Okay? All right. Hey, it looks like all of you are done taking the quiz in both classes, so I know we said 125, but we can get going. Everybody comes back on camera, please. How'd you do? You all right?
9.
Good, good. Fantastic. All right. Let's see, Tia, Lisa, Winter, Jasmine, Karen, Erica, you there? Come back on camera, please. Thank you. Okay, Erica, I can't see you. Everybody needs to be on camera. There you are. Tia, there you are. Winter, Jasmine, you there? Okay. Go ahead and share my screen and bring up the quiz. We're going to go through, everybody see my screen? I'm going to be going through, I didn't put any rationales in with this quiz. I'm going to be going through the rationales as we go through it. Okay. So there were a few primary, secondary, tertiary questions on this quiz. As I told you a couple of weeks ago, you're going to start seeing these on all the quizzes, primary, secondary, tertiary, as well as on your exams. And as you saw on exam one, there were several of those primary, secondary, tertiary. It's a big part of this class, understanding which is which. So the school nurse is engaging in primary prevention, which is appropriate. Okay, we know that the only answer that's primary is B. Okay, where and how do we just discuss where and how we obtain ongoing contraception? So that's a prevention. Okay, the rest of them are not primary. What is A? Providing a list of clinics that provide confidential pregnancy testing. What's that? Is that screening?
The screening?
Screening? Right, so that'd be secondary. What about C? Educating on the side effects of antibiotics for gonorrhea. What's that?
Tertiary.
Because
Treatment.
it's treatment. Right. Right. And what about D? What's D? Create a pamphlet describing an appropriate prenatal diet. What's that?
Tertiary.
Nope.
Tertiary.
It's a tertiary, Lauren.
It was a
You said
tertiary
why
because
is it? It's because she's already pregnant.
Exactly.
Obviously.
Exactly. So we're managing something, right?
Yes.
Okay. Okay, this next question goes to the concept from week 4 of the pregnant adolescent. Which counseling is appropriate to provide the pregnant adolescent? Does everybody understand why A is the correct answer? Why is A the correct answer?
Because she could still get sexually transmitted diseases from her partner if he's having
she can
sex with other people.
Okay. Anybody want to add to that? Wendy?
And she can transmit it to the baby.
Exactly. Yep. Right. We know that B is incorrect because there does need to be modifications for diet, right? Why is C incorrect?
because you start prenatal care right away.
Right. Right. The earlier the better. You know, if they're starting prenatal care in the Go ahead. Okay, and with regards to adoption, decisions must be made as early as possible. That's not necessarily true. Those can take time to develop, providing information, education, counseling. Those don't have to be made as early as possible. Okay. Question number 3. Which intervention should be prioritized for a child who has witnessed a violent crime? What's the important word in this question?
Prioritize.
Prioritize.
Prioritized. Okay. Do we understand why C is the correct answer? Okay, because they have witnessed a violent crime, we are going to try and obtain a referral for mental health counseling and services to see what help they might need. Okay, it's not that the other 3 answers, the other few answers couldn't be correct, but the question is asking to prioritize. Okay, do you understand that? Okay. Another prevention question. Which nursing intervention reflects secondary prevention for mental health? Secondary, we know, is screening. And the only correct answer that is screening is A, screening for depression and anxiety for each encounter. Okay, what's B? Primary, secondary, tertiary?
Primary.
Primary.
Right. Why is it primary, Michaela?
Because we're teaching before anything.
Right. We're trying to teach stress reduction techniques to young kids as to prevent any or to give them good coping mechanisms, right? Okay, what about C? What's C? Primary, secondary, or tertiary?
Search your word.
Why is it tertiary?
Medication and they already got something because they're
So
observing.
they already have something.
Exactly, Janisha. Good. Right? They're on an antidepressant medication for a reason. Okay, they already have a diagnosis or a condition or being treated. And what about D? Primary, secondary, tertiary.
Tertiary,
Why?
because they already have PTSD.
Exactly. Right, so this is part of a management or treatment program, right? Okay, good. Okay, which nursing assessment is the most important in clients abusing oxycodone? What's the important word in that question?
Most important.
Most. Yep, Alexis, most. So what would be the answer to that?
Breathing.
Apnea, right?
Apnea.
Right.
She's not breathing.
Right. It's not that there may not be some drowsiness, confusion, itching, but what is the most important? Okay, we need to think safety, our ABCs, right? Next question is a tertiary question, which reflects tertiary prevention and substance abuse. Okay, so the answer is C, arranging addict-led support groups to promote recovery. Okay. That's assuming they already have an issue with substance abuse. So C is the only tertiary answer. What is A?
Secondary.
Because it's screening. What about B? What's B?
Primary.
Because,
They're trying to prevent.
right, we're trying to provide information ahead of time, okay, of the dangers or the adverse effects of substance abuse. What about D? What's D?
Tertiary.
Nope.
Well, no, tertiary. Would it be primary?
primary, right? Trying to give tools ahead of time, right? Providing parents with adaptive coping mechanism skills so that when something may come up, right, they have the ability to handle it. Okay, this is an ethics question. This is from our week 5 concepts. Which nursing intervention reflects non-malfeasance? What is non-malfeasance? In your readings
To
from
do, for
Go
do
ahead.
no harm.
Do no harm. Okay, and we'll talk about some of the other ethical principles when we do our content. All right, so do we all understand why A supports the ethical principle of non-malfeasance, which is do no harm? What's going on in A to make that an example of non-malfeasance? Well, what's going on? Well, what's going on here?
There's
Apparently-
no injury.
Pardon me?
There's no injury.
Correct. The contaminated field, the sterile field was contaminated, correct? So obtaining a new kit and starting over is an example of non-malfeasance, do no harm. Right? We are attempting to do no harm by starting over. But look at the other 3. Inserting a feeding tube to administer meds in a client who swallows normally. Why would we be inserting a feeding tube? That the intent there is harm, right? Failing to document observed side effects to administered medications. That's harm, right? We have to be documenting. And then maintaining confidentiality of a fellow nurse who's working under the influence. Okay, do no harm. What's wrong with that? If you have a fellow nurse who's working under the influence, do you think you need to report that?
Yeah.
Yes, they can
Yes.
harm the patient.
Exactly. So maintaining confidentiality is in that situation is potentially doing harm. Right? Okay. So this next question is a hospice question, which comes from our week 5 content. So the hospice nurse notes that the client's pain is poorly controlled despite a fentanyl patch and as needed sublingual morphine. Okay, which intervention is appropriate. So in your preparation for this concept, what would be the most appropriate thing to do? If with a hospice client, the pain is poorly managed.
And you want to keep them
At
comfortable.
least no pain management.
Right. So at that stage, we would be notifying the healthcare provider for the need for additional pain management. Right? A doesn't make any sense for a hospice client. We're not concerned about addiction, right? Counseling the client and family that a pain-free death should not be expected. That's inappropriate, right? Because we do want to provide reassurance about pain, right? And that we will do everything we can to minimize their pain. What's wrong with D? Remove the fentanyl patch early and apply a fresh one in the same location. What's wrong with that?
Because you will alternate locations.
Go ahead, Theanisha. What did you say?
I said you will alternate locations.
Exactly. Same location is what makes the answer incorrect. Right? Client tells the hospice nurse, I don't understand why God is punishing me. What response is appropriate?
I got that one wrong.
Right. So let's talk about this. So in hospice care, we may not be prepared to have this discussion with the clients, right? As nurses. It is always good to ask them who we can get them for spiritual support. Okay, so do you have a pastor I can call for you? Okay, that is the most appropriate response. Okay, if you say A to them, what's wrong with that? You're acknowledging, right, that they need to be punished.
And what
Right?
about D?
Pardon me?
What about D?
Okay. Let me go to C first. C, dying is just a normal part of life, not punishment. That's also inappropriate. D, I have a lot of students who answer D. What makes you think you're being punished? The reason why that's not correct, it's then asking them to explain what they did or what they're referring to. And that may not be, it's having them maybe relive or retell something that they think they're being punished for. And that is not helpful
So
with, does that make sense?
kind
It
of.
does now that you said it, but I thought it was D too.
But what's the
More of
difference
being
if they're
therapeutic.
speaking to a pastor or something about
Because
that?
the
Like, it feel like
pastor,
reliving it.
because
Yeah,
the because the pastor is more able to handle those kinds of conversations. Okay,
I
it
think
may
it
not
was
be us that are fully equipped to handle those conversations.
Cause I thought like what I feel like what we learned as nurses was like always ask like an ongoing question to kind of see where their mental status is with it.
Right.
So, I don't know. That was a confusing one.
It was.
Can I
And
interject something?
yeah, of course.
In some cultures, they believe that they need to be punished in order to get to heaven, and the more suffering they have, the better it is for them. So when they say, why is God punishing me? They either don't want to be punished, or maybe they're saying, why am I not being punished enough? So only their spiritual leader would know which side of the coin that was on, because you don't want to counsel someone on saying, no, you haven't done anything wrong. God's going to accept you, when they're thinking in their head, if I haven't done anything wrong, I need to suffer more. Does that make sense?
Mm,
uh,
not really. I really don't get it.
Mine was
Because everybody don't believe in spiritual type of thing.
right, because that's what I was gonna say. I didn't want to assume that the patient had like a
A
pastor.
spiritual
Like,
When we were
relationship.
talking,
right.
You're
then,
not assuming, you're
You're
not
not
assuming
assuming.
anything. If you're going to talk to them about it, you're assuming something. If you want them to get the care they need, you ask them for their spiritual leader. Now that person understands them. They've been counseling them all their life, probably. And the family. So, and some people want a medicine woman. They don't want a reverend or a pastor. Some people need a rabbi. So you just
Right.
don't know. But there are religions where they make themselves suffer in order to get to heaven. And they want to suffer more. And I don't understand it. It's not part of my religion, but it's my job to understand it for them.
Hmm.
Right?
Yeah,
Right.
but if they want to suffer, then they would the question say, I don't understand why God is punishing me. So if that's their religion to be
Because they may be expecting you to say, because he wants to make sure you get to heaven. You see what I'm saying? It's a backlash. That's why we don't counsel them.
yeah,
I don't
Well,
know.
and they can also say
Again,
no. When you offer them, do you have a pastor? They also can refuse that request.
Yeah.
okay. I'm gonna have to agree to disagree with this one.
Right.
I think y'all
I
pick
feel
C.
like if most of the class
I
got
picked
D,
D.
I feel like that should be a question that got challenged or something, because nobody really understood that one.
Okay. I appreciate that feedback. We'll have a look at it. Thank you, Janisha. Last question. Client with metastatic cancer has made the decision to stop all cancer therapies. Which statement by the nurse reflects a respect for the client's autonomy? What is autonomy? What did you learn in your preparation for class? What is the ethical principle of autonomy? Well, what is being autonomous? What does autonomy mean?
Being self-aware.
Independence.
Mhm.
Making
Allowing,
decisions, making your own decisions.
exactly. So in this situation, we are encouraging or respecting clients' autonomy, right? So they have made the decision, so we have to respect that. So would you like help in sharing your decision with your family? Shows your respect for their decision. Okay, the other three are disrespecting their autonomy. Let me see if a physician can talk to you about the benefits of radiation. They've already decided that they're stopping all therapies. So that would be an inappropriate response. C, you're actually questioning their decision. Do you think this is the best decision to make with regard to you and your family? That's totally inappropriate, right? We're questioning their decision, and that's disrespectful. And then by saying D, I've heard new chemotherapy treatments are not awful. Again, you're disrespecting their decision. Okay, do we understand why A is the correct answer here?
Yeah.
Okay. Okay. Let's cover a little bit more. Oh, go ahead. Somebody have a question? Okay. Okay. In week 4, these were our concepts that were covered. Okay. In some specific special vulnerable populations, your pregnant adolescent, your LGBTQ populations or individuals with mental illness issues, and then specific alcohol, tobacco, and other drug problems. Okay, so let's start by talking about pregnant adolescents. So what challenges, asking you, what challenges do pregnant teens face?
Like nutrition,
Nutrition.
self-esteem issues,
Okay.
and
About like
fear.
their education.
What about their education?
Like, because sometimes if pregnant teens in high school, maybe they tend to have a higher rate of dropping out.
Okay.
Housing issues.
Housing issues.
Not having enough support.
Not enough support. We know that there's a direct correlation that exists between poverty and pregnant adolescents and poor health outcomes, correct? There's a higher risk of STIs. There's a higher risk of drug and alcohol abuse. There's a higher risk of poor nutrition. What are some of the nutritional needs from pregnant adolescents have?
Protein, any vitamins,
Iron, maybe. I'm thinking of
that-
like the prenatal vitamins.
Folic acid.
Okay.
That's what it was, folic acid.
What about accommodations? What do you think accommodations in schools for pregnant teens? What do you think some accommodations might be?
More bathroom breaks, maybe.
Okay.
Yeah.
Okay. Maybe allowing them to miss school for appointments, allowing them to make up work or exams or whatever for appointments. What other accommodations? We make sure
Having
that,
snacks.
pardon me?
Having snacks on hand. for
Okay.
pregnant girls.
I was going to suggest having nutritional meals available for them. And maybe to-go bags for evening meals and weekend meals. What other accommodations can we think about?
Parenting classes?
Oh, good one. Yes. Yes. And because we want to get them back in school as soon after, maybe accommodations for childcare. Right? Accommodations for community resources if they need them.
Would that include like tutors?
Sure. Whatever resources, whatever accommodations we can provide them to be successful in school during their pregnancy and then returning to school after. Because what we know is that the sooner they can return, the more education they can have, the more benefit it is to them in the current situation and long term, right? Better decision making, better ability to seek out resources, right? We know that racial and ethnic minority groups have higher rates of teen pregnancy, right? Why is that? Well, there's higher rates maybe of poverty, lack of educational opportunities. We know with teen pregnancy, there's higher rates of abuse and violence. Domestic violence is a very, very much an increased risk for teen pregnant moms. Low income, maybe lack of social support networks. Why is it that occasionally or sometimes nobody knows about the pregnancy and they're afraid to seek prenatal care? What's going on? What are some of those risks? Maybe don't want their family to know, don't want their friends to know. Maybe just denial. What else?
It could be like religious
Mhm.
conflict.
Okay. So let's say you're the home health nurse and you're doing postpartum visits for new teenage moms. What are you going to be looking at? What do you want to see? What are red flags? What do you want to see? What would you like to be observing in your home health visit?
A safe environment?
Safe environment. What else?
Like a happy child.
Making sure
like
that
non-smoking.
Non-smoking. What about the interactions with the baby? Is that important to observe? And what do you want to observe?
Yeah. You want to make sure that the mom is bonding with the baby so the baby gets
Exactly.
appropriate care.
Right. Can they meet the need? Can she meet the needs of the baby?
Right.
What is the environment? Is it a calm environment? Is it a hectic environment? Does she have the resources that she needs? Is the family
the
involved?
support. Right.
Yeah. Is the dad involved? Right? Does she have an awareness of growth and development, milestones? Right? What would be some red flags?
bruising
Maybe
on
like
the
yeah, I was gonna say like maybe
Or
the
not
clothes.
interacting with the baby.
Go ahead, Lindsay.
I was just gonna say like I was thinking like looking at the environment, like if the house is unsafe, like a mess, you know what I mean?
Yep. Yep. There's a lot of risks, both during the pregnancy and after the pregnancy. And if you're working with teen moms post-pregnancy, there's a safety evaluations or safety assessments, environmental assessments, knowledge assessments. Is there a language barrier? Is there a literacy issue with understanding what's going on? Okay. We'll talk about our LGBTQ population. Okay. You're caring for these individuals or families. We talked about this, I think, in week 3. It is critical for us to have an understanding of our own feelings. What do you remember about that conversation? Why do we need to have an understanding of our own feelings? What potential risks does that involve in caring for this community? Why do we have to assess our own feelings?
Because we may have our own
Hey.
personal biases.
Yeah. You know, we may have personal biases. We may have different values, may have different judgments, but we have to work through those to be able to provide culturally competent care, right? Do you remember that discussion? Culturally competent care. We as nurses are in a position that we need to be providing culturally competent care to all vulnerable populations. And that includes the LGBTQ. So understanding our own values, beliefs, practices, and how they may contribute positively to caring for this population or inhibit culturally competent care with this population. Okay, this population really does need a safe environment to be able to discuss whatever their sexual orientation, their sexual practices, but they need an environment that is compassionate and non-judgmental, right? Stereotyping and discrimination, I mean, they're experiencing that through their whole lifetimes, right? And we as nurses need to have that open mind and providing them safe spaces for them to be able to talk to us, tell us what their needs are, for us to be able to do appropriate assessments or competent assessments. They need to feel comfortable. Okay. Couple of examples. Rather than making assumptions about clients based on their appearance or sexual behavior, with open-ended questions, right? So rather than saying something like, are you married? Right? Or do you have a boyfriend or girlfriend? How about, do you have a partner? Right? Or are you in a relationship? Right? So we need to think about those open-ended questions. Okay? And these will help initiate a further discussion into what their needs are and how we can meet their needs. One thing I want you to understand is the CDC. Okay, the CDC has recommendations on screening for the prevention of STDs with this particular population. Take good notes here. Okay, actually it's right here. It's your 4th bullet. So the CDC has recommendations for STI screenings, and these are the 5 recommendations. Okay, and this is annual. Okay, recommendations: HIV, gonorrhea, herpes, chlamydia, and syphilis. Okay, that's an annual recommendation. However, if the particular person is at higher risk, okay, and there's two reasons they would be at higher risk. Okay, first is if the individual has multiple or anonymous sexual partners, that's one, or if they're using illicit drugs during sex, that's the second. If they fall into those 2 higher risk categories, the screening is then bumped up to every 3 to 6 months.
What was the first one? I'm sorry to use before the
You're going to get
drugs.
asked about right here. It's right here in the 4th bullet, HIV.
No, you said something about like before you said illicit drugs.
Oh, the first one. Multiple or anonymous sexual partners.
Okay, thank you.
Yeah. Okay, so that or using illicit drugs then puts you in a different category of being screened every 3 to 6 months. Okay, but the typical recommendation is annual. Okay, and that's what are the screening intervals? We just went through that. Okay. But in caring for this population, number one, most important to understand your own feelings. And if you're not able to provide culturally competent care, you're going to have to work through those feelings or find the resources you need to overcome whatever prejudices or biases or judgments you have. Because we do have to provide this community a safe environment to be able to do competent assessments and take care of them. Okay. Mental illness. Okay. Again, foundation for a good nurse relationship, nurse-client relationship. It begins with a thorough understanding of our own self-awareness. Again, with this group of these vulnerable groups, what our beliefs are, what our biases are, what our feelings, what our values are. I don't know how you feel about taking care of clients that have significant mental illness issues. You know, talk about our homeless population, teen pregnancy, LGBTQ, people with mental illness, people with substance abuse issues, alcohol, drugs. Okay. So again, taking care of all these populations starts with our own self-awareness. Okay, we know that anxiety, mental illness, we know anxiety is expected. And I started to talk about this in my concept review. All right, we know that that is a common emotion. Okay, it's considered normal. Okay, but when it becomes so debilitating that it impairs our daily function and our ability to get things done, that's an issue. Okay. We know that most patients are at risk for anxiety disorders because of physical, psychosocial, developmental, cultural, and spiritual things that affect all of our lives. We're all at risk because of all of those things. That's how we manage to cope with them. Okay. Let's talk about a couple. Well, that's on the next page. What is general anxiety disorder? What is that? What did you learn from your readings? You had a whole chapter about certain diagnoses. What is general anxiety disorder? Anyone? This big class. Anybody? Tell us what general anxiety disorder is.
Feeling manic all the time?
Pardon me?
Are you asking like what is it? Like how do you feel when you have it?
Or what is
feeling
it?
manic all the time. A general
Worry.
feeling of overwhelmed.
Okay.
Uncontrollable worry and fear.
Okay. Take notes. Persistent, unrealistic, excessive worry about this is a general anxiety disorder. You're worried about 2 or more life circumstances for at least 6 months or longer. That's the specifics of it. Okay. People with general anxiety disorders worry more than is considered normal or average. They worry about multiple things at the same time. Okay. Phobia. What's a phobia?
Fear of something.
Fear.
Excessive, irrational fear of some kind of activity, situation, or object. This is from the book. Okay. This extreme fear leads to avoidance or extreme anxiety that interferes with your normal daily functioning. Okay. What about let's see, PTSD? What's PTSD?
Post-traumatic stress disorder.
And what is it?
Having a fear of something has traumatized you before, so that's a trigger every time it comes around.
Correct. An event. It's an event that is either threatened death, threatened serious serious injury to either you or others, which you experience an intense fear, helplessness, or horror. And then that remembrance, right, of that event produces feelings of intense distress, intense anxiety, okay, flashbacks. Okay, there's several mental health questions on exam 2. So I'm going through the ones that I want you to have a basic understanding about. Okay, and this isn't on your PowerPoint, but I'm going to bring it up. What about suicidal ideations? That's another form of mental illness. When we care for, let's say, a client who has suicidal ideations, what are we most concerned about? What do we need to be thinking?
Safety.
In our plan, safety. What kinds of things do we want to know? Do they have a plan?
Yeah, do they have a plan?
A gun or a weapon?
Do they plan to harm themselves or others?
Exactly.
Have you tried this before?
Have you tried this before? Excellent.
Maybe how long have you been feeling this way?
Exactly. Do you have the means to carry it out? Right? Have you, maybe somebody already said this, have you attempted this before? All really important questions. Kids. As we know, with all vulnerability, kids are at the highest risk for mental illness. Why do you think that is?
Lack of education. Some kids not in school.
Okay.
I think it has to do with maybe their parents
And emotional
with,
support. How they
because they're just
cope.
so vulnerable.
They deal with a lot of bullying.
And their brains are still developing.
Exactly. Great answers. Great answers. What about them being potential victims of abuse or neglect? What about them witnessing abuse or neglect? Maybe witnessing domestic violence with their caretakers, parents, guardians. And what about the lack of advocacy for them? We saw through COVID, with all the lockdowns and being out of school, all the social isolation, right? Not being around their buddies, not being around their friends. I can say that I was still working in the schools when everybody came back to school from COVID, and the exponential increase in mental health issues with children, elementary, middle, high school, were significant. Okay. And that's just an example of what the pandemic did. Okay. One of the medications that I want you to be familiar with is lithium. Okay. Lithium teaching plan. Okay. What do we know about lithium? Okay. When we're teaching clients that have either just starting it, or doing assessments on how they're doing with lithium.
Take it with food.
Right. Encouraging normal, it's right here at the bottom of your PowerPoint. Encouraging normal salt intake, reporting diarrhea, reporting any kind of vomiting, tremors, or lack of coordination. Okay, we know that lithium is used as a mood stabilizer, and it's in particular used with bipolar disorder. Okay. When we talk about alcohol, tobacco, and other drug problems, okay, we do know that substance abuse contributes to teen pregnancies, contributes to STIs, contributes to domestic violence. Okay, it contributes to child abuse, child neglect, motor vehicle accidents, physical fights, assaults, crimes, homicide, suicide, right? Tobacco, let's talk about tobacco for a minute. Tobacco use and what diseases it contributes to. What did you learn about tobacco use and the dangers of in your readings?
Like the secondhand smoke.
Okay. What about pulmonary and lung diseases?
Yeah, like COPD,
COPD, emphysema,
emphysema.
secondhand smoke with kids. What about
Causes a lot of ear infections in children. Secondhand smoke.
What about let's say you're a home health nurse and you're working with a family whose parents smoke and kids live in the house. Okay, and the parent talks about, and you're trying to help them towards the goal of say a smoke-free home. What about the vaping? Does that contribute? Is that a good thing? Is that just as bad? What if they say I vape? It's okay. I don't smoke, I vape. What did you learn about vaping?
It's still as bad as like smoking.
Exactly.
A regular cigarette or anything like that.
Exactly. What do we think are some of the contributing factors to substance abuse?
Maybe having some past trauma.
Okay.
Like family, like having like a support system.
What else contributes to substance abuse? What about poverty?
Yeah, like stress, poverty,
lack of education, maybe
mental illnesses.
Yeah.
Domestic violence.
Domestic violence. Human trafficking. Right? I want you to look through, have an understanding of these terms that are in your book. Okay? These are the ones I want you to understand. What's the definition of substance abuse? How does that differ from drug dependence? Withdrawal, detox, what is that? What's the difference between drug dependence and drug addiction? What is polysubstance abuse and what is alcoholism? You need to have a good understanding of those. There are several questions on the next exam about each of these. Okay, so just have a basic understanding of these. Okay, and these are all from the chapter in your book. Same with the psychoactive drugs and substance specifics. What is a depressant? How is your body affected by it? What are stimulants? What's an example of a stimulant? How is your body affected by it? How do energy drinks, nicotine, tobacco, vaping, alcohol, cocaine, amphetamines, meth? How do these affect your system? Think clinical. Let's say somebody came to your clinic and there was a suspected amphetamine, methamphetamine overdose or cocaine overdose or abuse. What might you observe? Okay. And these are all covered in your book. When we talk about community-based activities aimed at substance abuse prevention, here's some ideas. What? I'm sorry? School activities. What kinds of things can we do in the schools? Think primary, think secondary, think tertiary interventions. What can we do? What's some primary examples, primary prevention examples of substance abuse prevention?
Like when I was in
like
school,
your
they
DARE
used to
program.
Oh, well, yeah. There you go.
That was a
Go ahead,
DARE program.
Janisha.
Oh, no, it's okay. I was just gonna say how they used to have like people come out and talk to like students about different effects and things and like how drugs can affect your body, your mental and stuff like that.
Yep. What about secondary? Remember we talked about screening. Can you screen for students who might be at risk for substance abuse issues? Screen for kids who might be at risk for behavioral issues, right? Are there student assistance programs? Are we also working with the parents? Do they have an understanding of how would they detect if their child was impaired, or what would be the warning signs that their kids are doing things they shouldn't be doing? Right? Having extracurricular, extra activities for students to participate in. Maybe parents not allowing drinking in their home. Doing some teaching and education on anti-peer pressure skills, because we know a lot of young kids in the substance abuse issues come from peer pressure. Right? And then doing the screenings, like we talked about, for kids at risk for alcohol, tobacco, or other drug issues. Okay. Let's get into our week 5 concepts. Okay, this week, hospice and palliative care, death and dying, faith and spirituality and culture, faith community nurse, ethics, and then just a comment about the American Nurses Association. So one of the big clarification on what's the difference between hospice and palliative care. A lot of times you think of those as meaning the exact same thing. What's the difference?
So hospice is where it's
Hospice
just
is like end of life care.
Okay.
comfort
And
care.
Hospice, end of life care. What's palliative care?
Pain management.
Pain management, comfort care, maybe.
Comfort care. So let's say, this is the best way I could describe it. Let's say you're diagnosed with cancer and they've said you have a couple of years to live, a year to live, 6 months to live, or not 6 months, like a year. Palliative care is that
Palliative care.
comfort, pardon me?
They go on palliative care to provide comfort and pain management.
That's exactly right, Corey. And then when does it transition into hospice?
When they have, I'm guessing, about 6 months or less to live.
Exactly. So there is, Corey, excellent. There is a difference. Palliative care is the care leading up to hospice care. Once you're in hospice care, there is still palliative care being provided, comfort care. But the time leading up is the palliative care. Right, Corey? Do you want to add to that?
Yeah. No, I'm okay.
No, that's awesome. Thank you. Right. So when we're talking about clients with hospice, palliative care, we need to focus on the needs of the client, right? We're keeping the client comfortable. We're trying to maintain dignity. We're trying to maintain self-esteem. We're trying to practice the ethical principle of autonomy, which is having the client be as involved as they possibly can with their plan of care. Okay? We want the client during these times to be able to interact with the family and participate in their healthcare decisions, right? We know that palliative care, hospice care, there may be a lot of people involved, a lot of family members, friends, relatives. And it's not that their needs are not important as well, but the patient, our clients, those needs are primary. Okay? The prescribed treatments that the client wants us to do is what we should be carrying out. Families may differ in their clients' decisions or decision making. And Dr. Kopteros, please jump in if you want to add anything from all of your Jerry experience. Please jump in. Okay. The goal is to alleviate suffering as much as possible, right?
Well, I can say that palliative care is generally used for the older adult who has multiple chronic conditions. It does not mean we're going to withhold treatment. It means that we're going to only treat what they want treated. If you have an older adult with COPD and they're also type 2 diabetics and they have an exacerbation of COPD, so they need to get prednisone, and they know, giving them prednisone is going to raise their blood sugar. So you have to put them on insulin. At that point, the adult can tell you, you know what? Just treat the COPD. I'm not going to follow a diet. I'm going to be happy and eat whatever I want until I die. So there's so many chronic diseases, conditions, but with the hospice, they're dying from one specific disease that there is no cure for, and they have 6 months or less to live. And they do receive palliative before it gets that bad. But if you're on, let's say you have a stage 3 or 4 cancer and you get, you fall and break a hip, that does not necessarily mean they're not going to treat the hip unless you're in hospice. Then it's like, we're not going to touch you. We're just going to let you die in comfort with dignity. Does that make sense, Professor Marvel?
Absolutely.
Okay, that's what we teach.
Absolutely. Does anybody want to add to that?
No, I just have a question to try to better understanding. So if you're at stage 4 cancer, you will start off with palliative care, right? But as you get to stage 4 and get to the end of the life, you will transfer over to hospice?
Well, at hospice, when you're in hospice, go ahead, Dr. Gutierrez, but the treatments have been ended.
Right. When you stop your treatment, at that point, it's going to only get worse. So someone may have stage 4 cancer and still receive treatment because maybe the tumor is less painful with the chemo. So we keep the tumor at bay by giving them palliative care, which has to be chemo. However, if there's no way we can make the tumor smaller, we stop all treatment. And at that point, we're just keeping the person comfortable.
Okay. Yeah. With hospice or just palliative care?
With hospice, we're only keeping them comfortable. There is nothing more we can do. They can decide if they want oxygen or not.
Yeah.
Okay.
All treatments have been stopped once you get to hospice care. Palliative care starts when that diagnosis happens and goes all the way through until the end of life.
Yeah, but with hospice, you still they still give them comfort and
yeah, it's still comfort care, maintaining dignity, quality of life, alleviating pain. There's just no treatments, and that's what that quiz question was about. The patient has made the decision to stop all treatment. Okay, what should we do? And the right answer was, okay, you've made your decision. Do you need help sharing with your family? The other 3 answers were not respecting their decision. Right? So look at this last bullet here. Aggressive treatments are stopped. Chemo, ventilators, dialysis, that's hospice care. Okay? So here's a good slide. Hospice care can occur. Where does hospice care occur? At home, long-term facilities, small clinics, hospitals. 6 months to live if all treatments are stopped. We need to be educated. We need to be knowledgeable as a hospice caregiver of the stages of grief. Okay, and that is in your reading. So there's some questions on the next exam about scenarios. A patient is saying this, a family member is saying this. What stage of grief is that? Okay, so there's your stages. Have an understanding of an example of what a client or a family member might be saying in each stage: denial, anger, bargaining, depression, and acceptance. Again, with this population, you're trying to use therapeutic communication, asking open-ended questions. How do they want their care managed? Okay, pain control. This was one of the quiz answers. We're not worrying about addiction. Okay, one of our goals is to have them as pain-free as possible. And then palliative, improving quality of life, alleviating suffering, and improving their overall feeling of how things are going. That's palliative care, trying to improve or maintain the quality of life for however that looks. Faith and spirituality. Well, cultural competence, we've talked about numerous times, and understanding of our own culture and biases, right? Every person is a unique individual. There's no such thing as a common minority, right? We know that some cultures are past oriented, present oriented, future oriented. And there's issues with each one of them. Okay. Past orient, I'm just reading from my lecture notes. Past orient, so take some notes here because this is on your next exam as well. Past oriented cultures, they value their ancestors. And the past can sometimes be so preoccupied with their past or with past events that it makes it difficult for them to achieve future goals because they're so focused on the past. Present-oriented cultures, all they're thinking about is the here and the now, the present, right? They're prioritizing their present quality of life. They're making decisions that make them just happy now, happy for today, happy in the present. Okay? But one of the downfalls of this is it may lead to decision-making that fails to plan for the future. All right, or fails to consider future consequences. And then you have cultures that are future oriented. And there's a chart in your readings about these 3 time frames: past, present, future. Okay, so have a look at that. Okay, but if you're from a culture that is only focused on the future, you're much more likely to make sacrifices now in order to achieve your future long-term goals. Okay, so each culture may have a different time focus, and it comes with positives, but it also comes with risks. Okay? When we're working with clients from different cultures, right, we need to gather data on these cultures. Gather data on the values, beliefs, expectations, practices. Again, in your reading, there's a chart that goes through several different cultures, and one column describes values, beliefs, okay, practices. You can't make any assumptions. If you don't know, ask, right? We don't want to treat every patient exactly like we would want to be treated because our cultures are vastly different. Okay, we want to be treating them as whatever their needs and values and practices, we want to try and incorporate as much of their culture into their healthcare plan. Okay? And then cultural competence. How do we know we're culturally competent? Well, we know that. Look at this last bullet, really important. We as nurses make a conscious attempt to learn about people of different cultures. And furthermore, we are attempting to look at the world through their perspective. That's cultural competence. That's what we are working towards. I've been working towards cultural competence for 40 years. Okay. But what I know is if I have somebody who's from a different culture, that's going to require different communication skills, different ways to approach them. I'm always willing to learn. And attaining cultural competence is a lifelong journey for nurses. And if you're already out in the working field, you're probably already working with many different cultures, correct? Well, you have to become culturally aware. Okay. we have what we call our in our religious spirituality section. There is a role called the faith community nurse, like the school nurse, like the occupational nurse, like the home health nurse, the hospice nurse. There is a faith community nurse. That faith community nurse typically works within religious places, whether it's a mosque, a temple, a church, whatever religion is being practiced and wherever it's being practiced. But this faith community nurse is usually incorporated into the team of that congregation. Okay, these may be the nurses that go out and do the visits after somebody's had a baby. These may be the nurses that do grief support groups. Okay, the goal of the faith community nurse, whatever religion you're practicing within and whatever venue you're practicing in, the goal is to incorporate whatever the religion, the spirituality into the practice. Okay. Faith community nurses practice health education, health promotion. They're trying to incorporate whatever community resources that are in the communities while incorporating the spiritual health and whatever the religious practices are. All right, their focus is holistic, mind, body, and spirit. Okay. Ethics. Let's talk about ethics. Okay. We should be basing all of our decisions every single day in all aspects of our life with ethics. What are ethics? Simple. What are ethics? To do the right thing.
Values.
Go ahead. Value. Go ahead. What else?
Maybe like your morals, your beliefs. Yeah, like what is right and what is wrong.
Right. What's morally right? Right? All of our decisions we make ethical decisions all the time. Whether it's in our personal lives, our work lives. Right? So in healthcare, one of the first steps in ethical decision making is you have to identify an issue. How are you going to go through the decision-making process if you haven't identified the issue? Right? So if you think of ADPI, we identify an ethical issue, right? We go and collect information. What would be some potential interventions or approaches we could use? Make a decision, implement it, and evaluate it. Okay, a lot of organizations, most organizations have ethical committees where ethical situations come up in those committees. And that is the process they go through. Okay, they don't provide care, the committee. They don't approve mental health issues. They talk about an ethical issue going on with a particular client in their organization. And they decide what is the best way to move forward. Here's some ethical principles. Moral distress. Right? Moral distress. We experience moral distress both as individuals and as healthcare workers when we're really unable to act according to with what we believe is the right course of action. So let's say a doctor has ordered something for a patient and you don't agree with it. That truly causes you moral distress, does it not? We talked about non-malfeasance. Okay, do no harm. But remember beneficence, do good. Okay, the most common ethical principles, beneficence and non-malfeasance. Non-malfeasance, do no harm. Beneficence, do good. Okay, so that would be do good. So an example of that would be ensuring adequate pain control. That's an example of beneficence, right? Doing good. Advocacy. We're always advocating for our clients, right? Finding them the resources they need, advocating for them if they don't understand something. We're always advocating for our patients. And autonomy. Encouraging the client to participate in their health plan. Okay? Don't worry about these last three. These are the 5 I want you to focus on: moral distress, beneficence, advocacy, autonomy, and non-malfeasance. And then lastly, American Nurses Association. What is it? Okay, so American Nurses Association represents all of us. Okay, they are, and there's a question about this on the next exam. Okay, they are general standards, not specific. Right? They're general standards and guidelines for nursing practice for all of us. They're broad and general, and they apply to all nurses across the nation. Okay, they're not specific to OB nursing. They're not specific to pediatric nursing. All the different specific organizations have that and have their own scope of practice and have their own ethical standards and ethical statements. But overall, the American Nurses Association represents all of us. So, of course, it's going to be broad. It's going to be general. They're guidelines for nursing practice. Okay. So I'm 3 minutes over my time, so I apologize for that. We covered a lot today. Did you guys take good notes?
Yes.
Okay. Does anybody have any questions? If there was any of this, oh, go ahead, Elaine. Go ahead. I can't hear you. You're on mute.
It was not a question. I was scratching my wrist.
Oh. If anybody needs any clarification or wants to review any of these concepts, please reach out to your instructor and schedule a tutoring time to do that. I will stay on for any particular, Dr. Pateros and I will stay on for any particular questions. But I hope everybody has a good week. What were my reminders? All the groups make contact with each other? All the groups doing?
Yes.
Still got a couple of weeks, but has everybody at least made contact with each other? Fantastic. Okay. And let us know if there are any group issues. But hopefully everything's going well so far. So I hope you guys have a great week. Reach out if you need anything. And good to see you.
Thank you.
Thank you.
All right.